of Policy and Data. I am pleased to welcome you to this webinar for the HRSA and SPINS initiative, Dissemination and Evidence-Informed Interventions, Lesson Learned from Replicating and Sustaining 4 Evidence-Informed Care and Treatment Interventions, which we will call CATIs, that link and retain people with HIV in care. Before we get started, just a few housekeeping rules. All lines will be muted during this webinar, and please use the text chat to engage with our fellow participants or to ask questions of our presenters. We would like to acknowledge our partners across the 12 sites who have been with us throughout this 4-year stint and a part of this initiative. Next slide. As we get started, I would first like to welcome our Division Director, Antigone Dempsey, as she gives us a few introduction words of welcome.
Thanks, Corliss. Hi, everybody. Good afternoon. And I just want to thank all of our partners who are presenting today, who are part of the Dissemination of Evidence-Informed Interventions Initiative. It's a long name, so but also referred to as DEII, I think, or you guys may have a better acronym for it. But we have our folks who are part of our Technical Assistance Center and also the Evaluation Center who are hosting today's webinar. And really the importance of this project is basically to take and look at interventions that have been tested or have been modeled before in SPINS funded initiatives, and to take those and to adapt them and to through those adaptations to sort of look at that, to evaluate it, and then to document how these interventions are being adapted and used in different settings or communities. And so really what Corliss was talking about, the CATIs are the result of that work. And it's just been very instrumental in terms of being able to create tools for our recipients and subrecipients on the ground to be able to take up different interventions to address making sure that folks with HIV are in care, engaged in care, and following up with folks. So just so you guys all know, we're part of these are also looking at some of our MAIF funded, our Minority HIV and AIDS Initiative funded projects as well. So this initiative aligns with our priorities around collaboration, innovations, increasing efficiencies, and also strengthening the well-being across the lifespan. So we really look forward to hearing from the presenters today. Really thank you all for coming and taking the time to joining us today. So I also just wanted to make a little note to let you all know that, you know, I heard yesterday in a director's meeting that what we used to always do as a lunch and learn time frame for these things in the COVID days of Zoom may not necessarily be the best strategy, given that we are all looking at a little screen or maybe a big screen all day long. So in the future, we're going to plan these meetings to happen before the lunch hour. I think as the weather's gotten better, people want to be able to kind of step out and get out, you know, move away from the screen. And so I just want to acknowledge that. And, you know, this is recorded. So for folks who aren't able to come today, we'll be able to share with folks later, but just to let you know, in the future, we'll make sure to sort of plan around just trying to help balance sort of wellness for all of you and all of us. So with that, I'll turn it back over to Corliss. Thank you.
Thank you, Antigone. Our main objectives today is to share resources and strategies about the care and treatment interventions, the CATIs, to reach vulnerable populations, including women of color, people transitioning from jails to the communities, and people with HIV who struggle with substance use disorders. We will also share strategies and approaches to build and sustain the HIV workforce, to link and engage people with HIV in care. So let's talk about some of the DEII initiative. The Dissemination of Evidence-Informed Interventions was a 5-year program managed by the Ryan White HIV/AIDS Program, Special Projects of National Significance, and it was the first attempt to adapt and replicate innovative interventions to scale across Ryan White grantees. The initiative funded 12 centers, the Implementation and Technical Assistance Center, which we call the ITAC, directed by AIDS United, and the Dissemination of Evaluation Center, directed by Boston University, in partnership with Apta Associates. There were 4 care and treatment interventions that were replicated: the transitional care coordination from jail to community, peer linkage and re-engagement for women of color with HIV, integrating buprenorphine treatment and opiate use disorder and HIV primary care, enhanced patient navigation for women of color with HIV. Next slide. The care and treatment intervention we used the implementation science framework to assess the lessons learned and process and outcomes. We used the Proctor model, which examines the implementation strategies of the 4 CATIs and assess both implementation and client outcomes. Next slide. So a little bit about the DEII interventions. First, we have the transitional care coordination. And the goal of this intervention is to facilitate continuous HIV care between jail and community settings upon a person's release within 30 days of release. The linkage is facilitated by a traditional care coordinator who works across jail and HIV primary care settings. Each site hires a traditional care coordinator to provide case management, accompaniment, and home visiting to address medical and social needs up to 90 days. Next slide. The second intervention, integrating buprenorphine treatment. With this one, the goal of the intervention is to provide opiate use disorder treatment in the HIV primary care setting, utilizing a one-stop shop model through the following steps, as you see here, that are listed on the slide. Next slide, please. Thirdly, we have the enhanced patient navigation intervention, which focused on the retention of care for women of color with HIV. And all of the women in this program were out of care for at least 6 months or longer, newly diagnosed in the past 12 months, or never in care and not virally suppressed. The intervention provided support and education activities to women, including intervention, provide transportation assistance, coaching on health education to improve adherence to treatment, accompaniment to medical appointments, and assisting with completing social and medical service referrals. Next slide. And last but not least, there's the peer linkage and re-engagement intervention, which utilize peers defined as people with HIV who have a shared experience and shared community membership as the populations that they work for. The sample of the women were similar to the patient navigation intervention, and they focused on women of color who were out of care or newly diagnosed. Next slide. With the transitional care coordination intervention, the sample size for linkage to HIV care was 229, and the sample size for viral suppression at 6 months was 154. Next slide. In the buprenorphine HIV intervention, there were a total of 94 people who received services across the intervention. And among those participants with available chart data in the post-intervention period, 74% of the individuals were linked to care within 90 days, and 71% were retained in care, as well as 88% achieving viral suppression. Next slide. Within the patient navigation intervention, a total of 332 women of color were served by this intervention. Among the sample of women who were out of care or newly diagnosed with available chart data, 76% were linked to medical care within 90 days of enrollment into the intervention. And among those, 74% were retained in care, having 2 medical appointments 90 days apart in the past 12 months. And among those, 65.2 achieved viral suppression. Next slide. And then with the peer intervention, a total of 196 cis and transgender women were served in this intervention. 173 were enrolled in the study and had available chart data. At baseline, 58.5 were virally suppressed, and as a result of the intervention, 95 were linked to care. Within 90 days of enrollment, 73 were retained in care and 81 achieved viral suppression. There was no gender identity found among the differences. Next slide. Here we have a list of our DEII replication and sustainability resources. We have our CATI implementation manuals, the training curriculum, our sustainability report, as well as our evaluation protocols, which all of these resources, as well as others, can be found on the Target HIV DEII site. And if you would just go to the Target HIV site, you will be able to find all of this information there. Now I will turn it over to Alicia Downs, who will talk to us more about our training and peer trainings.
Thanks, Corliss. You're a hard act to follow, but I'll do my best. Good afternoon, everyone. I am Alicia Downs and was the Senior Program Manager for the Implementation and Technical Assistance Center. Fabulous colleagues to acknowledge for this initiative are Hannah Bryant, Erin Northrop, and Joseph Sewell. So what we did is we proposed a no-cost extension to implement a training of trainers, I'll refer to it as TOT, and a peer-to-peer training program. The goals of the proposal were to increase workforce readiness to implement the DEII interventions, and then utilize this peer-based model to provide trainees with the information they need to replicate the interventions, as well as practical firsthand mentoring from folks who implemented these interventions across at the 12 sites funded for the DEII initiative. Next slide. So there was a method to our madness. What we did is we invited funded DEII sites to become mentor sites. One site per intervention if they had, one, sustained their programs, two, had a multidisciplinary HIV care team comprised of staff with direct experience implementing or overseeing one of the 4 interventions. And then 3, were able to identify 2 staff who could attend the 2-day TOT and were considered experienced or experts in their intervention protocol. I should share that the TOT facilitators were part of the original DEII training team. The TOT agenda really focused on facilitation skills, right? Because not all of us have those skills when we start this week. Allowed for attendees to practice delivering training content through teachbacks. And then those trainees were able to receive feedback from the trainers and their peers on the strengths and areas for improvement from their teachbacks. In addition, the training teams did receive follow-up coaching and support to ensure that they felt ready to co-facilitate the intervention trainings. Next slide. So the 4 training teams co-facilitated national peer-to-peer trainings with support from the TOT trainers. We followed the curriculum from the DEII training manuals, truly applying case examples and various strategies or tools that would support the learning of the trainees. Certainly our priority trainees were Ryan-wide HIV providers. And in fact, we had trainees from over 82 organizations across more than 20 states in the country. And then of course, we had to cross-promote the training. So we worked with our AETC colleagues to market these 4 trainings. We promoted it at the Ryan-wide All Grantee meeting last year, promoted it through the Paula Jones newsletter, the AIDS United listserv, through our previously funded DEII sites and varied community stakeholders. Next slide. So we began planning in-person trainings last year, and we know that COVID happened and we quickly had to pivot to offering these trainings virtually. So we really had to step back and rethink what our training plan would be by considering how do we adapt the curriculum to accommodate the virtual format, because not all of us can sit in front of a laptop for 8 hours. We had to have shorter training days with frequent breaks. We had to ensure that there were interactive activities, such as the use of chats, polling questions, Zoom breakout rooms. And we had to be mindful of challenges some of the attendees might have, such as their Wi-Fi capabilities, their laptops, if they had laptops, webcams, if they worked, and certainly their competing work priorities. Not to mention that many of us have kids who are also learning from home. Next slide. So we held 4 trainings from September to November of last year, all virtual. We had over 150 folks trained in the 4 interventions, 27 from the transitional care coordination training, 30 from the peer linkage and re-engagement training, 68 participants entered attended the buprenorphine training, and then 29 folks attended the enhanced patient navigation training. So to give you a sense of who the attendees were, they were physicians, nurse practitioners, pharmacists, case managers, patient navigators, community health workers, behavioral health and substance use treatment professionals, as well as administrators who were trying to identify how potentially they could take one of these interventions and implement it in their community as part of their response to the EHE plans. The patient navigation, the peer, and the transitional care coordination trainings were approximately 2 days each. The buprenorphine training was delivered in collaboration with the Midwest ATC located in Illinois. And with the buprenorphine training, what we did is we offered 1 hour weekly webinars over 5 weeks. Next slide. So yes, we did evaluate the trainings. We utilized 3 training surveys. The first survey went out 1 week prior to the training. The second one was sent 1 week post-training, and then there was a third one 3 months post-training. Surveys collected information regarding participants' confidence in performing intervention activities at their clinics, perceptions of the trainings and progress in implementing the interventions. And the survey methodology was utilized for the peer patient navigation and transitional care coordination trainings. For the buprenorphine training, what we did is we utilized the ATC's evaluation tool as our partnership with the Maytag, Illinois local performance site. Preliminary analysis demonstrated that the trainings did in fact impact participants' confidence to implement the intervention. Participants scored higher in their knowledge of and confidence in implementing the interventions post-training. So what we'll do now, next slide, Serena. So what we're going to do now is go through some slides. So bear with us. We know that these slides are a little bit busy, but we'll work through it. So the first set of data we're going to look at is for the transitional care coordination training. On the left side are various components that encompass the training agenda. These components measured understanding of the intervention and its core elements, confidence in bringing the intervention to their community, as well as confidence in processes that allow the intervention to function well, such as negotiating with correctional leadership. The red bars display participants' understanding of and confidence to implement key components of the transitional care coordination intervention pre-training. The blue bars indicate participants' understanding and confidence of these same components 1 week post-training. All responses were captured using a Likert scale where 1 was low and 5 was high. This group of participants had the greatest increase in their understanding of both the intervention model as a whole and how the interventionists operate as a liaison between clients and the court system. Next slide. So this chart is going to focus on the patient navigation intervention. Again, the training components included that are located on the left included understanding of a 6-part education curriculum, understanding of how the patient navigator works with clients and within the care team, as well as participants' confidence applying training content to their work. Trainees had the greatest increase in their confidence in delivering the education curriculum to clients and their understanding of HIV and antiretroviral therapy. Knowledge and confidence also increased across all components post-training. Next slide. Similarly, for the peer training intervention, knowledge and confidence increased across all components. Again, on the left, some of the training components included understanding what the peer role was, understanding the viral life cycle and how medications impact one's viral load, as well as CD4 count, labs and adherence, and then lastly, confidence in coaching clients about their health. Next slide. Lastly, as noted previously, we use a different evaluation format for the buprenorphine training because we collaborated with the Illinois AETC using their evaluation tool. When we looked at immediate post-training surveys, we find similar positive outcomes. So listed in this table are a sampling of objectives from the 5 buprenorphine webinar series. As mentioned, they were held in during 1-hour increments over 5 weeks. When participants were asked to what extent were the objectives met, all responses were above a 4.0 on a 5-point scale, indicating that participants agreed or strongly agreed that the objectives were met. Next slide. So some additional quotes from participants that really highlight the impact of these trainings are noted on this slide, not just in terms of increasing knowledge and confidence, but also in terms of building capacity within the HIV workforce to implement evidence-informed interventions. I really appreciated this one in particular, love the cases. They really help with the learning process. I think I have a clear understanding of next steps after the 5th in the series, and we'll go to the resources and start putting a plan together. So clearly this quote was from a person who attended the buprenorphine training. Next slide. So we had big plans. We were offering coaching and limited TA to participants following virtual trainings. And while COVID did in fact impact the quantity of technical assistance requests we were expecting, we have been able to support trainees in launching to pilot a peer program, thinking through adaptations to protocols if the intervention was being implemented by volunteers versus paid staff, and then providing references from the Target HIV website, the DEII tools and materials. Participants have also reached out to inquire about the possibility of attending a training of trainer on the DEII interventions or co-facilitating with us to deliver training content to other members of their organization, which speaks highly to the impact of the trainings. You know, I would be remiss if I didn't say we didn't experience some challenges. Back to the other side, Serena. So, you know, like with pivoting to any good virtual training format, it was really tough. And it was tough because some people were multitasking during virtual meetings. I mean, many of us have gotten really well at doing that over the last 12 months. Or some folks were pulled to do something in the clinic while they were scheduled to attend this training. Some folks didn't turn on their cameras, so it was really tough as a trainer to be able to read people's nonverbals. Some folks chose to fully participate while others did not, meaning that they didn't participate in maybe some of the small breakout group activities that we had. Some folks attended one day and didn't attend the full 2.5 day training. And while participants did have to register, did get reminders about the training, some folks just didn't show up, which certainly impacted other people who were waitlisted and wanted to attend. Next slide. So we never stop replicating training on these dissemination of evidence-informed interventions, and have certainly incorporated some of these products in other projects that we're implementing. This is a great example of collaboration with the South Central AETC and one of our former DEII mentor sites, Grady, and us will be delivering a Community Health Worker Institute at the National Latinx Conference, which is going to be held next month, and is going to be informed truly by the patient navigation training curriculum. So I'd like to now pass the mic to my colleague, Marina Sullivan.
Thanks, Alicia. Hi, everyone. My name is Marina Sullivan. I am a program manager on this project with the Dissemination and Evaluation Center. And I'm going to talk about how the demonstration sites sustain their interventions after the DEII initiative ended. So the DEII initiative was implemented by 12 Ryan-White HIV/AIDS program clinics from September 1st, 2016 to July 31st, 2019, with both funding and technical support from the Implementation and Technical Assistance Center. Next slide, please. So what we did is we developed and distributed a sustainability survey in June of 2020 to assess the extent to which sites continued to implement their interventions after the DEI initiative ended. So the participants of this survey were one core program staff member from each of the agencies. So 12 total sites, 12 total staff members completed this. The data that we collected were information on adaptations about the interventions, where the interventions were receiving funding to continue. And we also used the Program Sustainability Assessment Tool, or the PSAT, which is an organizational tool developed by Washington University. And this was used to measure the site's capacities to sustain their interventions at their agencies. And the scale examines sustainability by 4 subcomponents: environmental and agency level support, funding support, organizational capacity, and program adaptability. Next slide, please. So what we found from this survey is that of the 12 demonstration sites, 10 of them were implementing their interventions after the initiative ended. As of June 2020, they were implementing their interventions still. 8 of the sites responded to our question about how many clients they had served since the initiative had ended, and the individual sites reported that they had served between 300 and 501 unique clients between July 2019, when the initiative ended, and through June 2020, when we distributed the survey. And we found that the sites who did not continue their interventions attributed that to funding and staffing capacity. And although 10 of the sites had been implementing their interventions, we also found that one, which was a transitional care coordination site, stopped as of the pandemic implementing their intervention because they could not have access to going inside the jail during the pandemic. So as of June 2020, 9 sites were implementing their interventions, although one of the transitional care coordination sites had been prior to the pandemic. Next slide, please. So we asked all sites where they were getting their funding to either continue the intervention or some of the activities to serve their clients. And more than half of them were using some sort of Ryan-White funding to fund their interventions. 4 reported they were using program or internal income. 1 specified that they were using 340B program income. 2 sites reported using local funding. 1 reported using foundation funds, and 1 of the buprenorphine sites reported using SAMHSA funds to continue the intervention. Next slide, please. So here are the results from the Program Sustainability Assessment Tool. The PSAT uses a Likert scale of 0 to 5 with 4 to 5 questions for each sustainability component. So a 0 would indicate that the site staff that completed the survey felt that their organization had little capacity to sustain their intervention in the given area, whereas a 5 was the highest they could rank it, and that would indicate that they felt that their organization had a great capacity to sustain their intervention in that given area. So the left column is broken down by each PSAT sustainability subcomponent. So environmental agency support, funding support, organizational capacity, and intervention adaptability. And the top row is broken down by each of the 4 interventions. Now I'm going to draw your attention to the last column, indicating the average scoring for each sustainability component across all 4 interventions. So sites were more confident that they had the organizational capacity with a score of 4.2, in the environmental support with a score of 4.1 to sustaining their interventions, whereas they had smaller scores that they felt confident in that they had the intervention adaptability and the funding sources to sustain their interventions within their clinics. And now I'm going to draw you to the last row of the table, which indicates the average overall scoring for each intervention type. So overall, the peer and the patient navigation intervention sites scored higher with scores of 4.7 and 4.1 respectively in their abilities to sustain their interventions than the buprenorphine and transitional care coordination sites did, which scored 3.4 and 3.1 respectively. One potential reason for increased sustainability among peer and patient navigation sites is that they had higher scores in the funding, their confidence in the funding that they received. So there are a few, we see that the transitional care coordination and buprenorphine sites do tend to have lower scores. So at these particular sites, they may not have had the resources that the peer and patient navigation sites did to sustain the interventions. And now, lastly, I'm going to talk to you about some of the adaptations that the sites made to the interventions after the initiative ended. So each site that reported it had sustained their intervention in some capacity made at least one adaptation to the model or the original model. So the most common reported adaptations among sites were expanding the eligibility criteria for and extending the length of the intervention. So some examples of sites expanding eligibility criteria include one peer site, which reported that the original criteria for the peer intervention is serving women of color with HIV, and they expanded this to serve all women with HIV. One of the buprenorphine sites, which originally, according to the model, the site would serve people with HIV with co-occurring opioid use disorder, and they had expanded their eligibility criteria to include also people who are at risk for HIV and have co-occurring opioid use disorder. And then an example of extending the intervention length was both at the peer and patient navigation sites. In this model, clients were originally assessed at 4 months, and they would be transitioned to the standard of care at that time, according to the model. And at least one of the peer and one of the patient navigation sites reported using this 4-month period to assess clients, but they didn't necessarily transition them to the standard of care at this point if they had a high acuity and didn't complete their care plan goals. And then a few other adaptations were related to what the staff roles were and the level of effort that interventionists had on the intervention, the supervision structure of the interventionists, and related to the internal clinic support and integration. Next slide, please. So if you're interested in reading more about specific adaptations sites made to the intervention models, we have this sustainability report available on Target HIV, which is one of the resources that Corliss mentioned. This is just a screenshot from one of the pages there. But to sum up what we learned about this sustainability survey is that most sites were still sustaining their interventions in some capacity, and most sites secured funding through at least one Ryan White funding source. Sites tended to think they had more organizational capacity and environmental support within their agencies to sustain the interventions, as opposed to the ability to adapt their interventions and to find funding for the interventions. And the most common reported adaptations to the models were expanding eligibility criteria and the length of the intervention. So that is the findings from our sustainability survey. And now I'm going to turn it over to Mo at AIDS Care Group.
Good afternoon, everyone. My name is And I am a program manager at the AIDS Care Group. I served as co-PI for the DEI initiative for the peer program. So a little bit of background about AIDS Care Group. We were one of 12 sites that were funded for the SPINS project for 2016 to 2019. So we were incorporated in 1988. We are located in southeastern Pennsylvania, which has been historically a medically underserved area. We now have 2 more clinics. One is in Sharon Hill in Delaware County and the other one in Reading. And so we provide a range of services, mostly HIV primary care. We have a dental clinic. We provide Hep C care and screening and treatment for STIs. We do PrEP, and we have a psych department also that also offers substance abuse treatment and counseling. We first received Ryan White funding in 1999, and now we're funded through parts A, B, C, and D, and we've had a few SPINS grants the past couple of years. We have about close to 1,000 patients, active patients, and about 10% of that on average represent new patients seen annually. About close to 70% of our patients are minorities, and 40% of our total population are women. So this project was great for our patient population. So for the initiative, we were able to enroll 80 women of color in the peer linkage program. We found 12 women who were newly diagnosed, and mostly got these women through referrals from the health department and nearby hospital systems. About 30% of the total population was in the linkage program were African-born women, and they mostly came from West Africa. Some had recently migrated to the US, and some had been in the US a little bit longer. The out of care range was 6 months to 5 years not been in care. The average age was 45 years. 3 women who are American born were also co-infected with Hep C, and so they were able to be treated and cured within the 6 months, 4 to 6 months of the intervention. 3 women also presented with active TB, and they were treated for that as well. The mean CD4 at baseline was 553, but the viral load was a bit higher at baseline at 75,000 copies. Next slide. So some of the peer intervention outcomes. So we did collect data at 3 months and 6 months post baseline. And we also did 6-month chat reviews, medical chart reviews, and also at 12 months. So this is more of the data from the medical chart reviews. And at baseline, prior to enrollment, the virus suppression was about 75%. And linkage to care, which was defined as one primary care visit within 90 days, was at 97% after enrollment. And then retention to care, which was defined as 2 visits within 90 days apart, also went up to 81, almost 82%. The viral load also 12 months after enrollment increased from 75 to 86%. So we were proud of those numbers. One of the highlights of our peer linkage program, this is our star peer specialist. She had been a volunteer with the AIDS Care Group prior to the SPINS project, and so she had a lot of wealth of information and experience being a client and a volunteer, so she was the perfect fit for this project. And she had a really powerful story and just always seemed to share her story with a lot of women who could relate with her. And one of the quotes that she shared when I did ask her about why she loved doing this job was, she said, when I was diagnosed with HIV, I had no one to help me and keep me in care. This program is the most beautiful thing, especially for women of color, because so many of us don't put ourselves first. I enjoy every minute of the work I do, and I know that it makes a difference. So we found that sharing a personal story was a crucial component of outreach and re-engagement. It sort of removed this stigma of, being out of care for so long and just getting back into care. She had every story based on medication adherence, just talking to doctors about things that didn't feel comfortable talking about. She served as a great liaison between the doctors and the client. We found that personal stories also added an extra layer of support for clients who were newly diagnosed or just were having a hard time with linking back to care. And she did not give up on clients. She just did a really great job with handheld navigation process. So along with that, we did have a wealth of data. And so we did present our data and lessons learned at different conferences like Ryan White 2018, Synchronicity, Association of Nurses in HIV Care for the last 2 years, and the American Anthropological Association. We were able to sustain the peer intervention. It was easy for Allison to transition into the general outreach program because the staff knew her, the medical team knew her. So that was easy to do that. We continued support services like transportation using program income. We also have maintained strong partnerships with the local health department and other support services providers in Delaware County who refer patients to us. And we also use them to find out how clients are doing as well. And most recently, we did receive another SPINS funding targeting Black women. And it's been a great opportunity to work with folks at DEI again, and we'll utilize lessons learned from that initiative to carry on with this initiative. And the funding has also helped us to hire another community health worker who also will learn some of the things that we used in the peer program. So happy to be back on the SPINS team again. That's all I had. So I'll pass it on to Tajma.
Hi, good afternoon, everyone. My name is Tajma Washington. I'm a patient navigator at Grady Health System. I'm going to discuss the patient navigation intervention at Grady Health System. Who are our patients? So since 1993, Grady's IDP, Infectious Disease Program, has been housed at the Ponce Center, located in the heart of the city. The Ponce Center is one of the largest, most comprehensive programs for the treatment of advanced HIV in the United States. More than 60% of people served at the Ponce Center have advanced symptomatic HIV disease. The Ponce Clinic is Atlanta's major provider for care of adults, adolescents, and children living with HIV. In fact, Grady treats 1 out of 7 persons living with AIDS in Georgia. Next slide. This is our wonderful intervention team. This is from, I'm going to name them from left to right. You have Lucy Warren, Tajma Washington, myself. We are the navigators, data manager, LaShawna Johnson, and program coordinator, Larissa Carnes. We also had a clinical supervisor, Gina Herring, who met with us regularly. Next slide. So inclusion criteria. IDP serves over 6,000 patients, of which more than 1,500 are women. So it was important that we had a specific identifying potential participants. The slide shows some of our inclusion criteria. patients coming for appointments, but not undetectable. I had a patient that was enrolled in the study and she was self-navigated, but due to her rising viral load, her provider referred her to the study and she needed that extra layer of support. I met and introduced myself to the patient. She enrolled into the study, but she had difficulty engaging. And I did a baseline acuity assessment, which was completed to determine her needs. And with that tool, I was able to identify her lack of emotion while speaking and her knowledge about HIV and HIV treatment. So depression was a factor in the client's on and off again adherence. The client was attending primary care appointments regularly, but wasn't virally suppressed. So during the first 3 months of our face-to-face encounters, I would do most of the talking, and the client's response was very limited. The client began to engage more after our educational session 3, understanding the CD4 and viral load, when I introduced a graph showing the trends in her labs. I asked the client what were some factors that have kept her from taking her medicine. She listed factors as forgetting, too tired, not eating enough, and overworked. I also asked the client to list benefits list the benefits when she takes her medicine, and she said that she had more energy, less aches and pains, and clearer thinking. So while enrolled in the enhanced patient navigation project, weekly calls, sending affirmations, text messages, and HIV education sessions assisted with building a trusting relationship. I worked closely with her primary care doctor and her mental health provider to ensure consistent messaging in her care. This also helped the client clarify each healthcare team member role in her care. Next slide. So myself, her provider, did develop a care plan, and the acuity tool that was used was to develop a patient care plan with her. The client agreed to come in twice a month, and she agreed to commit to taking her medicine for 7 days. Later on, the client agreed to meeting with her mental health counselor and a primary care doctor during the same visit. So soon the weekly visits became monthly, and 7 days became 30, and she became undetectable. After 6 months, another acuity assessment was given. Needless to say, her engagement in care improved. By being transitioned to the standard of care, she continued to maintain an undetectable viral load and fully engage in all her medical services. Working beside these women and seeing their journey has been amazing. Next slide. So, Grady's vision was to implement a patient navigation program. We applied for the DEII funding, which was a program focused on women of color living with HIV, and build a care team that included patient navigators. After the vision, we saw an opportunity to extend patient navigation program, in which was leveraged through more state and city funding, and more patient navigators in other clinics that serve Grady Ponk Center, which includes our Family and Youth Clinic, which serve women and children 13 to 27, our main clinic, which serve men, the Majority AIDS Initiative, which focus on serving Black MSM, trans women, and patients who are at risk of falling out of care. The HRSA Spins Black Women First initiative focuses on Black men ages 18 to 44 living with HIV and patients at risk of falling out of care. The HRSA Spins initiative we are part of includes a virtual patient navigation through an app called PL Cares. So through the PL Cares mobile application, it offers self-monitoring tools and educational resources. We are able to build off the DEII intervention and execute other patient navigation projects. And I'm going to hand it off to Corliss for questions.
Thank you, Tajma. We do have about 10 minutes left for questions, so we will open it up to our, our audience if you have any questions for any of our participants here today.
Hi, Carlos, this is Serena. I have a question for Tajma and Mo, if they could just comment on their experience, because we have many HRSA project officers here today, and I know you all are clinics. So if they were to provide resources or information and experience about patient navigation and peer interventions to their Part C funded clinics or some of their grantees, what are some of the recommendations that you would have for them on how to implement these, the peer and patient navigation interventions?
For me here at Grady, implementing the intervention, it was extremely helpful that the stakeholders were excited about the intervention, and that included the providers and the nurses, and having great relationships with them to discuss the patients. So that was very helpful.
I would say relying also on like community partners, like I shared with our data, 12 of our newly diagnosed women were mostly referrals from partner organizations around the county. And so working together, not just in the clinic, but with other service providers that could potentially funnel clients in need of services.
Okay, thank you. And I see a hand raised from Antigone.
Yeah, thank you. Thank you all for wonderful presentations. Really helpful to hear. I wanted to ask you, Mo, when you talked about the referrals, what kinds of organizations were referring these new clients? Because I think people are really trying to think about creating new partnerships, and it'd be great to hear what kinds of organizations you were able to connect with to share those referrals.
Sure. So mostly for newly diagnosed, we get them from the health department because a lot of people go there to get tested, and but they don't do any medical services. So they will be the first people that they call to send new clients. Also, we have a longstanding partnership with the county jail, which is one of the largest in the county, and so they see a lot of HIV patients, and we do discharge planning for them. So they, if we find any clients who either need services or have never been linked or just tested positive in the jail, so when they get out, they know where to go for medical care. So I would say those two were our primary referral sources, as well as we worked with other support, like if we had women that needed domestic violence services, we had other clients that we would also refer to outside of our clinic as well.
Hey, Corliss, in the chat, Chow has a question about where we can find the CATIs, the care and treatment intervention manuals, and Marina put the link on the website.
Yes.
And in the chat, you know, I always think that the Target HIV website is the best kept secret. And I wonder if there is a way, you know, we could potentially develop a webinar for Ryan-wide providers on how to navigate that website.
Also, along with the CATI manuals, there are other resources in terms of the evaluation protocols and so forth. So there are a wealth of information and resources. The training videos that are both the training videos that Alicia talked about are there, which are both in Spanish as well as in English. You can find those on Target HIV as well. Do we have any other questions? We have a few more minutes. If we have, I don't want to slight anyone. If we don't have any more questions, I would like to thank everyone for joining us today. I would like to thank all of our presenters for the dissemination of evidence-informed replication and intervention and webinar. And again, we ask you to visit the Target HIV intervention site for all of the resources there that we have, which has a wealth of information about the initiative, various websites, various resources, presentations that we have done over the years. And again, as Alicia said, there will be, I'm not sure, Alicia, you may have some more information, there will be another training coming up at the Latinx conference. I'm not sure if that is still open, if there are any project officers that are interested in possibly attending that particular training. And also, if you have any other information or you would have any other questions, you can always reach out to me, Corliss Heath. I am in the Division of Policy and Data, and I serve as the project officer for this great initiative. Again, thank you and enjoy the rest of your day.